For those that don't know me, I'm Tony Collier. I'm a trustee of Tackle and vice chair, but I'm also a man who's been living with advanced stage prostate cancer now for 7.5 years. Tackle are now responsible for supporting over 130 prostate cancer support groups across the UK and have recently received funding from the National Lottery to expand into areas of greater need. We offer support group leaders resources to help them run their groups and opportunity to share their experiences with other support group leaders. We are the only patient-led UK-wide charity representing people with prostate cancer and those who care for them. We have a special guest with us tonight, Hashim Ahmed. He's a British surgeon, medical researcher, and author of publications in the field of prostate cancer diagnostics and treatment. His research has contributed to changes in the way men with prostate cancer and men with prostate enlargement are diagnosed and treated. He's Professor and Chair of Urology at Imperial College Healthcare and Consultant Urological Surgeon at both Charing Cross Hospital and Cromwell Hospital. Professor Ahmed currently divides his time between clinical practice and research, and he's here tonight to tell us about the Transform trial, the biggest ever trial into prostate cancer screening. Hash, as he's known to friends and colleagues, will answer any questions that you may have, but please can you put questions in the Q&A area, and Sarah and I will ask Hash to respond after his presentation. So welcome, Hash, and without further ado, thank you for sparing Tackle Prostate Cancer the time to tell us all about this vital trial, and over to you.
Tony, Sarah and Kelly and Tackle, thank you for asking me to take part and give this talk. It's a real honor and I'm delighted to have said yes. And thank you all who've joined us for spending your valuable evenings to join us today. So I'll try and share this. So I've been asked to talk about Transform, which many of you will have heard about. Hopefully you can see my slides. Tell me if you can't, Tony or Kelly. So I do a lot of research, and one of the key things around research is that it is the result of confusion and uncertainty. And I think if I do one thing, I will probably cause confusion at the end of this. But that is really the point of why we're doing Transform. Because there is so much confusion, because there is so much uncertainty, we really do need to shift that dial with new research in order to help men going forward. And I'll try and explain why we need this trial going forward. Before I start, it is important for you all to realize whenever you listen to a so-called expert speak is that we are all biased and conflicted. I'm a urologist, I do NHS work and private work, and personally benefit from the prostate diagnostic and treatment pathway. And I do run a large research group, and therefore I'm supported by commercial and academic funders like Prostate Cancer UK and other charities to conduct research to improve the care of men. So I'm vested in this. I believe in what I do, but I also believe in making sure we do things properly and efficiently so that we get the right answers that people can't sort of pick holes too much at, but in a swift as manner as possible. It is important to recognize these two figures. Over 12,000 men every year in the UK will die as a direct result of prostate cancer, and over 55,000 men are diagnosed with the disease every year. And that's without any formal screening program. Screening is where the government sends out an invite to eligible people in the community and says, come and have this test. We do not have that yet. And it is really important to recognize that those men are diagnosed and those men who die from the disease. But it is also, on the flip side, important to remember that 1 in 3 men above the age of 50 have prostate cancer, tiny little bits of abnormal cells that we would call prostate cancer that will not cause them problems. That's a staggering figure. And if we screen for prostate cancer, one of the dangers is that we find this group of men who would never have known about their cancer and would never have had any problems in terms of quality of life or quantity of life. This is a complicated figure, but if you concentrate on the top row, the top 3 rows, it tells you what happens to men when they are diagnosed with low-risk prostate cancer. And the dark gray or dark blue band tells us how many men die of the cancer and how many men die of other causes. So a minority of men with low-risk disease, the types of cancer that we find in 1 in 3 men, don't actually die from their prostate cancer over a 10 or 15-year period. And if we find these men, we can end up causing them harm unnecessarily. And that is really at the crux of the whole debate. As you can see from the lower 2 bars of graphs, once you start to diagnose medium and high-risk cancers, those dark blue bars or graphs start to dominate in terms of the mortality, the deaths they cause from prostate cancer. So we need tests that can tell us which are medium and high risk, but we need also tests that don't find those low-risk cancers. And it's the balance between that harm of finding low-risk cancer and the benefit of finding important life-threatening cancer, which is at the heart of this debate. So is there a benefit in screening for prostate cancer? Is there a benefit in sending out an invitation to all men over the age of 50 up to the age of, let's say, 70 or 75, and asking them to have a PSA test? And if you then have a PSA test that's above 3, to then go on to have further tests to find prostate cancer if it is present, and if it is present, to then treat it. We have 3 studies that have looked at this very question over the last 2 decades. The first, which is the one that's reported the most recently, is the UK CAP study. And this study was a large study. You can look at the figures at the bottom of this graph, which shows you how many men were involved. In the control, which means nothing happened, they just carried on with their normal healthcare through their GP. And the intervention, which is, in the case of a UK CAP study, an invitation to have 1 PSA test. So this was 1 PSA test. They were not routinely asked 2 years later or 3 years later to have another PSA test or another one 4 years later. So this is a one-off PSA test. So it is criticized for not continuing to ask men to have a PSA test. These graphs are called Kaplan-Meier curves, and what it shows you is over time how many men suffered the event of death. The other way around is sometimes how many men survived. In this case, as you go through time, a number of men die of prostate cancer. And as you can see, the 2 lines overlap. And statistically, there is no difference. You can see a bit of a parting at 14 to 16 years. And there's a little bit of a difference at that point. When this study first reported at around 10 years, there was no statistical difference. It's now reporting much longer term follow-up. So it's just about showing a tiny, tiny difference. But it really is a tiny difference in survival from just a one-off PSA test. This is the US PLCO study, and they, again, hundreds of thousands involved in this, and they showed no difference between regular screening with a PSA test and a group that was the control that was supposed to not have any regular PSA tests. But what happened in this study is that there was a lot of contamination. And what that meant was that the control group, which was not supposed to have screening, most of those men, because knew they were part of a study, they had PSA testing. And so this study showed no difference in survival between screening and the control, but it was heavily criticized because the control group, the normal group, had lots of PSA tests in the background that the investigators only knew about afterwards. And that's something called contamination. And contamination means that the effect you're trying to see is being diluted by the fact that the two groups look the same. Men having a PSA test will have some benefit from having that cancer being found, and therefore it will be much more difficult for screening in a trial to show a difference in survival. And I'll come on to this because it's really a critical point in Transform. And then finally, the study that everybody talks about, the European multi-center trial, you can see that there were many more deaths in the control group, the red line, and fewer deaths with the curves parting in the intervention in the screening arm. And in this study, they were able to minimize contamination. So the control group really didn't have that much PSA testing going on. And they were able to do regular PSA tests. So every 2 years, sometimes every 3 years, depending on which country you were in and which country participated in this study. And so this is a study that everybody lauds because it's so robust and it does show a mortality benefit. But as with all these things, it's not that simple. So you can see, again, don't want to make this too complicated, but if you focus on the Netherlands and Sweden, those were the two countries that showed the mortality benefit. The other countries really didn't, and those two countries dominated the effect on the overall European trial. And why is that an issue? Well, it's an issue because the Netherlands and Sweden are perhaps genetically made up in a different way. And if we're looking across Europe, maybe there isn't a benefit in Belgium, Finland, Italy, Spain, Switzerland. And perhaps there isn't a benefit in the UK in screening for prostate cancer. So whilst in its entirety, the European trial showed a benefit, it was dominated by two countries. And so people are questioning whether there's a genetic issue here rather than a disease issue and a screening issue. But that is an overall assessment of screening. When a man tests positive with a screening PSA, in other words, the PSA is above 3, sometimes above 2.5, do we have a good test to find the cancer? And up until recently, we really didn't. Up until recently, in the UK, and still the majority of men in Europe and the majority of men in North America are getting transrectal biopsies of their prostate. So needles being inserted through the back passage with no attempt to clean the back passage. And that is contaminated. and causes harm of infection. It is also a random test. And so a lot of men internationally are still not getting an MRI scan before their biopsy, and we're taking random samples. And these random samples is exactly what CAP and PLCO and the European screening trial had. So harmful tests, a lot of men had them. A lot of men had life-threatening sepsis. Some, a minority, a rare number, would have died from their biopsy, a diagnostic test causing death. And, as we'll see, a hugely inaccurate test. And why is it inaccurate? Well, if you can't see the tumor in the prostate, you can't target it. So you take lots and lots of biopsies randomly, and the chance that you'll hit that tiny little one that doesn't need to be treated is quite high. You miss cancers because you can't see where they are, and you get a glancing blow on a cancer that is important and you call it unimportant. And those men can inappropriately go on to active surveillance, and they subsequently progress and end up getting higher risk disease and potentially metastases. So this test, the transrectal systematic biopsy test, has been the worst possible test I can think of in medical history. It really is that bad. It's a horrible test, and it's one of the most harmful tests that medicine has ever invented. PSA is not. PSA, adjusted for a great test and an accurate test, actually probably performs much better. PSA has been harmed by this horrible biopsy test. But as many of you will know, the UK has pioneered MRI before biopsy. And most centres, if not all centres, should be offering it to every single man before they do a biopsy. And we're pretty good in the UK. The US is still terrible. North America is still terrible. Europe is patchy. Australasia is doing much better. But we're pretty good. We're delivering MRI in a really good way across all of the NHS. And that means about 30 to 40% of men who would previously have had an immediate biopsy based on a raised PSA can avoid a biopsy because their MRI shows that they don't really have much going on. And MRI before biopsy improves the accuracy of finding cancers that need treatment. It actually can't see the majority of these tiny, low-grade cancers, which is great. We don't want it to see that, and we don't want those men to be biopsied and then told that they have low-risk cancer and then spend the next 10 years worried about it. Or even, God forbid, have treatment which is harmful, which we'll come on to. So we have changed. We're doing better. And we in the UK have pioneered looking at not only MRI in secondary care in hospitals, but potentially looking at MRI in primary care as a screening test in of itself. And that's what we're going to focus on in Transform. This is a scan that looks at the structure of the prostate, the density of the cells, and has a really good pickup rate of significant cancer, even in men with a PSA less than 3. That's what the data shows from the Reimagine study and the Prostagram study. I've had my prostate scanned. My colleagues, Henry Tam, Matt Winkler, and David Eldred Evans, one of our rising superstars in urology, we all had our prostate scanned in order to optimize the scanner. So before we scanned men, and we even had a Christmas quiz to identify which one belonged to which. And mine is the top left. I was actually quite worried when Dr. Tam was looking through the scan. I've been through, do I have it, do I not? But fortunately I didn't. This was a number of years ago. But when diagnosed early, so the point of screening is to find cancer as early as possible, cancer that would otherwise cause problems. When we diagnose it early, can that treatment benefit patients? And I'm afraid there's a lot of uncertainty and confusion around this as well. So this is the Scandinavian Prostate Cancer Group #4 study. They diagnosed men when there was very little PSA testing. Most of these men were diagnosed with high-risk, locally advanced prostate cancer, often with a finger up the back passage by which they felt a nodule, and they used 6 biopsies to find the cancer. And when they found it, they asked men, are you happy to be randomized between doing nothing, watchful waiting, and radical prostatectomy to remove the entire prostate? And you can see that death from prostate cancer on the left side graph. More men died after watchful waiting, up to 15 years of follow-up, and fewer men died after prostatectomy. But that difference is about 5 to 6%. So it's a small difference in a really high-risk group. A small difference in a really high-risk group. The graph on the right side shows us how many of those men progressed to systemic, in other words, metastases or spread of cancer. And again, prostatectomy prevented in a small group of men metastases occurring, but the effect size we would want to see is maybe not as large as we would like. So that was a high-risk group, and everybody concentrates on this study and says, yeah, treatment benefits men. Once you start to diagnose cancer early, so this is a US study, same design, where they took men who were diagnosed with prostate cancer, localized as far as they knew. This was early in the PSA testing era. So this is when PSA started to come into its own. In the US, lots of men were getting PSA testing. And so we were starting to find cancer much earlier in its life cycle, if you like. And they took men and said, are you happy to be randomized between radical prostatectomy and observation, they called it, watchful waiting. And they showed a tiny, tiny effect, which wasn't actually statistically significant. And they also showed a difference in terms of progression, cancer getting worse when you apply treatment. But these effects from treatment were deemed to be quite small, if insignificant. And look how many years we have to wait to see that benefit. And then this really threw the cat amongst the pigeon. Fantastic endeavor by Freddie Hamdi and colleagues. The PROTECT study took men who were diagnosed in the CAP screening study. So these were men who were screened with PSA, a one-off PSA test, but nonetheless screened and therefore found very early, and then asked them, would you be willing to be randomized between active monitoring, radical prostatectomy, and radical radiotherapy? And on the left side, you can see that very, very few men die of their prostate cancer. Fantastic. But no difference between the 3 approaches. There are 3 lines on that graph on the left-hand side, and they are completely overlapping. What it did show, though, is that if you treat, you reduce the chance of progression. So a graph on the right-hand side showing that cancer, the chance of cancer progressing was much lower. But treatment causes a lot of harmful side effects and negative impact on quality of life. That's because a lot of important structures are very close to the prostate, and they control urine flow, sexual function, back passage function. And if you treat the whole prostate, you will cause side effects. And these are the percentages of men who get urinary issues, urine leak requiring pads, erectile dysfunction, back passage problems. And these treatments sometimes don't work, and you need to do further salvage treatments. And men are not happy about this. This is the COMPARE study where we asked men, over 500 newly diagnosed men, what trade-offs they would be willing to make between side effects and survival. And men would be willing to trade off up to 0.5% improved chance of survival for a 1% improved chance of keeping their erections. And similarly, for every 1% improved chance of keeping their continence and not leaking urine, they were willing to trade off 1% of survival. And those kind of percentages mean that those benefits we've seen in survival of 5% at most from treating prostate cancer versus doing nothing are wiped out. Now, not every man will want to trade off in this way. This is an average effect, but it's quite revealing. But you say to me, Protect had a lot of low-risk cancers, and we're doing really well in doing active surveillance in the vast majority of low-risk cancers in the UK. But wouldn't it be nice if we didn't find these men in the first place? Because being on active surveillance causes anxiety and some men depression and some men suicidal ideation. So it's not a great thing if we can avoid it. And how many stay on active surveillance? How many get worried and switch over to treatment unnecessarily, even when they know it's not going to benefit them, because they just can't live with the strategy of active surveillance? And how many medium risk cancers, which again are slow growing, are managed on active surveillance rather than inappropriately treated? So when we are screening, we want to find the important cancer that is likely to spread if we left it to its own devices, and not find cancers that don't spread. And we need to do better with treatment. So focal therapy, where we target individual areas of cancer, really needs to come to the fore now. That's because you see a 5 to 10-fold lowering of side effects when you apply focal therapy in eligible men. Not everybody's eligible, but a massive drop in side effects without compromising survival over a 5 to 10 year period. We need more data over 10 to 15 years for survival, but the side effect profile is massively different. But of all the men who could have focal therapy in the UK, 12,000, most are not told about it, and most are not given accurate information about it. And if they do ask about it, they are put off from even finding out about it or having a consultation. That's not good enough. The charities are doing better now, and I've just plucked out a few of their websites, and focal therapy, which is HIFU or cryotherapy, is now starting to get prominence in most charities, but not all. And charities must advocate for informed consent and making sure men are aware of all of the options. Charities are not here to be paternalistic. So what does all this conflicting and contradictory information mean for screening? Well, first of all, what else do we know? We know that a one-off PSA is useful information, and I'll show you what that means. We know that a short 10-minute scan, maybe we can get it down to 5 to 10 minutes, in the community, instead of a PSA, finds cancers that PSA misses. And we also know that polygenic risk score, this is Roziel's work, based on doing a saliva test, might also be useful. So this is, again, showing the number of men who were diagnosed with prostate cancer over a number of years based on their original PSA. And you can see that the orange bar at the bottom represents men who have a PSA less than 1. So if you have a PSA less than 1, your chance of developing prostate cancer over a 12-year period is extremely low. Low enough probably for you not to have another PSA for at least 5 years, if not longer. We know from the prostagram data that we can model different pathways and see how many men end up getting a biopsy versus how many cancers we find. And this is a graph illustrating lots of different pathways. And the pathway that seems to work the best, the optimal, is number 8. And number 8, lo and behold, is you start off with a PSA of 1. And if it's above 1, sorry, you start off with a PSA. And if that PSA is above 1, you do a prostagram MRI. And that leads to about 7% of men needing a biopsy. And you find 2.5% of men who have cancer. At the moment, PSA testing on a screening level would lead to about 10% of men needing a biopsy. So we're doing fewer biopsies potentially with that approach. PSA 1, then do a prostagram if it's above 1, then do a biopsy if the prostagram is positive. So fewer biopsies, more cancers being found. Number 1 is, by the way, a screening PSA of 3 leading to a biopsy immediately. So you can see how bad that one is. And if we do deliver screening, we are going to have to invest hundreds of millions in scanners, biopsy equipment, digital health, urologists, pathologists, oncologists, nurses, allied health professionals like radiographers, lab technicians, physiotherapists, and administrators. We can hardly cope with what's happening now. And so if we're going to make that hundreds of millions of pounds worth of investment and look at those graphs in terms of just MRI scanning capacity, red is what we're doing now, blue is what we're going to have to do if we show in Transform that things work with screening. So all of this means that we have to look at screening, I'm afraid to say it, in a dispassionate way. The passion needs to come in at some point, and the individual patient stories are really important. And I'm not trying to downplay those 12,000 men who die every year. It was the first slide that I showed. But in order to prove that screening is the right thing, we need to tick off all of these criteria. These are the criteria that regulatory bodies use to determine whether screening should be approved or not. And hence, into that vacuum of evidence, that uncertainty, that confusion is Transform. And I'm very grateful to my colleagues who co-lead this with me, and also the massive team who are co-applicants. And we want to conduct a robust, pivotal, randomized trial of novel prostate cancer screening strategies. We want to provide results that will demonstrate acceptability of screening and its effectiveness and cost effectiveness. And we want to show that screening can work in the UK. So we want to understand what stops men from saying yes when that letter comes through the door. And we want to future-proof the study by collecting additional blood, urine, and saliva, and other types of tests, as well as collect all of their imaging tests, so that we can do future research in biomarkers. Existing biomarkers that we're not testing in Transform can also be tested in the Transform Biobank. And I know this is eye-watering, and I know it's frustrating that we have to wait for so long, but you can see those timelines on those graphs. You don't see the benefit until at least 10 years and possibly even 15 years worth of follow-up. And so we have 3 stages, and each of these stages will lead to data being released. And so we will have data being released. And if that data can help the UK and National Screening Committee make decisions, then we are very keen on that happening. And we have involved and liaised with the National Screening Committee in order to do that. And they will have first dibs at whatever data we produce so that we can see whether guidelines should change. And we're going to recruit men between 50 to 75, and in men who have higher risk, 45 to 49, and use a lower PSA threshold. But they can't have had a previous prostate cancer diagnosis, and they mustn't have had a previous PSA test, previous MRI of the prostate, or other biomarkers, or a prostate biopsy. At the moment, we're defining that as a 5-year period. And we're looking at different interventions. So the standard PSA first, if it's above 3, you have a prostagram MRI. If it's abnormal, you have a targeted biopsy. In the second arm, it'll be a PSA of 1. That triggers a prostagram and then a biopsy if it's positive. And in the third arm, we'll be carrying out a prostagram in everybody regardless of their PSA, but we will be measuring their PSA level. And in the fourth arm, we'll be determining what happens to men based on their polygenic risk score from the saliva test that you will have read about in the news. And that will give us information about which arm performs most optimally. Not the best, but most optimally in terms of number of biopsies, number of high-risk cancers, medium-risk cancers, and low-risk cancers, and quality of life metrics, patient-reported outcome metrics, and do some initial cost modeling to see which one might be useful in the UK. And transform centres, hospitals who want to take part, they need to be in regions where there hasn't been organised PSA testing in the region over the last 2 years. They can deal with the additional burdens. The biopsy must be targeted and transperineal only. They must offer active surveillance robustly. They must offer a portfolio of treatments that has to include focal therapy. And there will be quality checks on those centres deliberately, because I'm afraid we are all biased and we can always end up slipping, and we mustn't ensure we slip in any of these quality metrics. And then I'm going to end this talk with a few things. I know some are upset about Transform. Why? Well, the first concern is that Transform is delaying the government saying yes to screening. And that's a really unfair criticism, because people have been trying to get the government to approve screening for the last 2 decades. And to think that the government and the regulatory authorities were just about to say yes, and they've stopped because of Transform, is very unfair. And the reason is because many, including the UK Screening Committee, have said there is still uncertainty about the survival benefits once you take into account all of the studies. The European screening trial survival advantage occurred in just 2 countries. There's still too many harms of biopsy and treatment. And the harm reduction strategies we've used so far in the UK have not been associated with a screening study. So they can't be absolutely sure that those harm reductions will apply when you start to screen hundreds of thousands, if not millions. And so we need new evidence to link the survival advantage of screening that we've seen in the European screening trial with a reduction in the harms that have actually happened. The other criticism is the Europeans are doing screening now, so why are we waiting? They're not really. So this is the European Commission. They want us to assess prostate screening. They want us to consider general health system factors, including risk-benefit ratio and including costs and cost effectiveness. They want us to pilot and further research the feasibility. Does it actually work when you ask men to have a screening test, and the effectiveness of implementing organized screening programs? They are far from recommending screening. And is Transform sending the wrong message and discouraging men from having a PSA test? Absolutely not. Awareness raising, if men still want to have a PSA test, they should go on. But let's not fool ourselves. Transform has and will have little to no impact on the willingness or otherwise of men having a PSA test. When invited to have a screening test for prostate cancer in those screening studies, only 20 to 30% of men said yes and actually turned up. So are men already voting with their feet? Rightly or wrongly, that's their choice, but everybody's choice should be respected. And it makes a big difference to how big a study Transform needs to be. If only 40% of men accept the invitation to take part, we need to recruit about 500,000 men into the study. If 70% say yes, we need 150,000. So the proportion of men that say yes to joining the study has a massive impact on whether we can do this study quickly and get an answer quickly. And acceptance to the invite to have screening tests. If a sufficient number don't say yes, this will dilute any survival advantage that we see in Transform. This means a much bigger number to the point where we may not be able to do the study. And actually, if it takes that many men in a study to show such a small difference, why should a country invest in such a program? Especially if most men are showing that they don't want to be screened for prostate cancer. And why is Transform not allowing men who have had a previous PSA test to take part? Let me illustrate this. This is 1,000 men in the community who have a 3 to 4% chance of having prostate cancer that will cause them problems if it's not diagnosed. If 10% of those men have a PSA test, let's assume 3 out of those 4 in every 100 benefit, they get diagnosed and they get treated. But those 3 men will be removed from the pool of men that we could recruit into Transform and show a benefit. So we're removing those now. And if we then approach this group of men and let's say 400 say yes, that means rather than the 16 men who might benefit from being diagnosed in Transform, that number drops to 13. What if a lot more men have PSA tests in the community from which we are recruiting into Transform? That means, let's say, for argument's sake, all of those red highlighted men benefit by having a PSA test and they're removed from the pool of patients that we can recruit from. They've had cancer, so why should we recruit them again? And then if Transform approaches men and there's a significant overlap, rather than finding the 16 men in that 400 who say yes to Transform, that number is going to be 8. And it means the trial has to work that much harder to the point where it may never show a difference compared to this group of 400 where there isn't much background PSA testing. So contamination is a massive, massive issue, and it could destroy any result in Transform. And that's why we're taking it very seriously. Because if the background PSA testing in the UK is high, this will dilute any survival advantage we might see in Transform. This means that the UK doesn't actually need a screening program because public awareness is good enough, but PSA testing will continue to be patchy. And that means only certain groups of men will benefit, which leads to unequal access to healthcare. And then finally, will Transform exclude Yorkshire? Sorry, I've spelt it wrong. The YCR charity are considering setting up their own regional prostate cancer screening study. Because men can't be invited to two studies simultaneously, and because both studies are going to have a significant overlap, we are going to have to exclude Transform in Yorkshire if YCR also fund a study in that region. A better approach would have obviously been to join forces. And then we have to insist on focal therapy being accessible to men. We cannot afford for these harms to carry on being conferred on men generation after generation and killing the argument for screening. Because I can assure you, these rates of side effects that radical surgery and radiotherapy confer are unacceptable in a large number of men. And we mustn't make the mistakes of previous generations. We expend so much energy trying to find that one tumor in the majority of cases, and then to remove it or irradiate the whole prostate just doesn't make sense. So finally, in Transform, we want to take the cancer control benefit that we have from the European study, improving treatment of cancer for men who have advanced disease, and we want to stitch that together with the harm reduction strategies we've seen from MRI, transperineal targeted biopsies, active surveillance, and focal therapy, so that we can finally put this argument to rest. Thank you very much.
Thanks, Hash. That was a really interesting summary of the reasons why Transform is needed and also of the trial itself. Sarah and I are going to take it in turns to ask questions that our attendees have posted, but I'm going to start off with one of my own because I'm the chair today and I'm allowed to. So the timescale for me is a concern, and you alluded to that anyway. As you know, 12,000 men are dying every year from prostate cancer. And if we get no results of any note from Transform for 10 years, that's another 120,000 men. What should we be doing in the meantime, in particular, to avoid and reduce de novo stage 4 diagnoses?
Yeah, no, it's a really good question. I guess what I would say is if Transform didn't exist, we would still have that same 10 years of not making much progress because it's such a big thing to start screening that government, national screening committees, others do not support it. So we can only raise awareness. Charities are doing it. All charities do not have the deep pockets that a legally mandated screening program would. And so, we can only carry on doing what we're doing. But if you look at what's happening, when does PSA testing go up? It's when a celebrity says, I have cancer. But that peak does not stay. It peaks for a bit. It peaks only in certain populations who read the Times or the Daily Mail or look at the BBC breakfast program. The vast majority of men, I'm afraid, don't. And so the only way to make any headway into reducing those mortality rates is to get to a formal screening program. And all I can do is promise you that I'll do my best to get us there as quickly as possible. We will release data that we think is pertinent, that is pre-planned to be released, that might be helpful for the debate, that might shift the needle.
Thanks, Hash. Over to you, Sarah.
Thank you, and thanks, Hash, for such a great and very clear presentation. I've got a question here from Gordon. I'm assuming that he's in Scotland because he's asking, does this mean for Transform, as Scotland has blocked HIFU for prostate cancer, that there will be no centres included within Transform for that area?
I hope not. There are centres now interested in starting focal therapy. So Fife, Edinburgh, I think Aberdeen and Glasgow are also interested. So by the time we start, I'm hopeful that at least one centre will be starting to do focal therapy. It is a big issue. Men can't even get referral into England to access focal therapy, which is a big problem.
When will you actually
Thanks very
start
much.
recruiting?
I think realistically it's going to be second quarter next year.
Okay. Another question, again, this is actually one of mine, not from the attendees. You talked about the take-up rate for men who were invited for screening, and you said it was very low. How does that compare to other cancer screening programs in the UK?
So much lower. So I think I don't know the exact figures, but breast cancer is much higher. Um, I guess one of the things is that those studies are studies. So it might be that men are just reluctant to take part in research. And if there was a formal government letter from their GP saying, come and have a test for prostate cancer, we might get higher uptake. So that's one of the unknowns, but it has been a consistent figure. It's 20 to 30%. We are going to do some engagement work and focus group work to see if we can design our invitations better to try and increase that uptake. Certainly in Sweden, it's higher, but in other European countries, it's about 20 to 30% as well when they've done studies. So seems to be a consistent figure.
Okay, thanks for that, Hash. Another question here from Ken Mastris. What will happen to the program if evidence comes from either Europe or the US from a risk-based system?
So the evidence will always be constantly looked at independently of Transform by the National Screening Committee and anybody else advising the government. So that is the case with any trial, really. And the question you have to ask yourself is that evidence relevant to the UK, to the UK population? Can it be delivered in the UK? And those are questions that the National Screening Committee will ask. If we are halfway through recruitment and the National Screening Committee announces that screening is going to be approved and the government go for it, then Transform will stop and we'll put all our efforts behind a screening program.
Fantastic.
And then an
Thank you.
anonymous question. Given there's no screening program now, if PSA tests are to be effectively deterred to allow Transform to come through, what will the timeline be before effective testing can be provided? Are we looking at a significant time period where men are still at risk for undetected medium and high risk cancers?
Yeah, it's a good question. So I wouldn't use the word deterred. We're not deterring anybody from having PSA tests. All we're saying is whatever engagement activities and awareness activities you're doing are not going to make that much of a difference, I'm afraid. You just don't have those deep pockets. And you can't get at all men. And so we're not deterring them, but what we're saying is if we include men who've already had a PSA test, that background PSA testing that's going on, we will affect the success of the study, and we can't afford that. You can't afford that for us to do that, make that mistake.
Okay.
Alan Taylor from the Isle of Wight, they are a large group over there that do a lot of community PSA blood testing events. And Alan wants to know, well, he suggests that the biggest problem is, one of the biggest problems is why men decide not to have a test. And that when they're doing their PSA testing over in the Isle of Wight, when they're promoting PSA tests, it's often people's misapprehension around the DRE test. And that is often sort of a barrier to people even thinking about having any sort of diagnostic test for prostate cancer because of the barrier around having a DRE. I guess that sort of speaks really to sort of what you were saying earlier on about how you're recruiting people and making sure that you're sort of the messaging going out. So you mentioned earlier on that you were going to be doing some focus groups and stuff, and I know that lots of our support group leaders and support groups would love to be able to sort of help you with that in any way that they can. So is there anything you can say about that?
Yeah, DRE is a big it's a big controversial. I think it's not a great test. But yeah, and it's a misconception. GPs think they need to do it. It's not that useful. Men think they need to have it if they go and have a PSA test. But it's not just the DRE. Men have access to Google now, and there's plenty of nightmare stories about the biopsy and the side effects that treatment causes, that, men will be put off by those things as well. So it's across the whole pathway. And yes, please, we will ask Tackle for their help in giving us feedback, as to how we recruit. And men can't volunteer for the study. It is by invitation only because of the way we've designed it. But anything you can do to help us input into that, the design of how we approach those men and raise the acceptance rate. Anything you can do in the community to say, guys, if you get a letter that says, come and take part in Transform, this is what it means. Seriously consider it. Don't just throw it in the bin. I'm not asking you to tell them to take part, but they should consider it so that they can give it more thought. And that would be great as well.
Yeah, and as you can imagine, we are very keen to help.
Yeah.
A couple of questions on geography, really. Any developments in the southwest? This is from Tim Bond in Bristol. Will Transform be spread evenly across the UK? And another question from Roger Bacon. You said recruiting men in areas where PSA testing is happening will be avoided. The charity Picasso runs PSA events in Sussex and Hampshire. So will those areas be ignored when recruiting?
No, so that sort of background awareness raising by charities, we just accept is going to happen. And that's what's happening in the UK. So we have to compare what Transform is doing to what's happening now. And we have to show a benefit above that. Regions that where their GPs wholesale sent out a text message to every single man over the age of 50 or every single man with a certain risk, and asked them to have a PSA test over a 1-year period or a 2-year period, I'm afraid you just can't take part until that effect has been washed out, which might take 2 or 3 years.
Okay.
So there will be some patchiness. It's inevitable. All studies have that. Some regions just, some hospitals, some of my colleagues will not accept what I've said and will not abide by the criteria. But that's I'm not here to force anybody to take part.
So I guess there's probably just one question, Tony Moore, or is that?
Maybe two, yeah.
Okay. So my question then is from Ramesh. He said, what will you be doing to make sure that you can access men in diverse communities when recruiting? So especially thinking about Black men.
Yeah, so a lot of work. So we've shown that ethnic groups need to be approached in different ways. The language of how we approach them, the way in which we approach them has to be different. And having a uniform approach is just not going to work. In Prostagram, we had 20 or 30% of Black men taking part, so that was pretty good. So we're not going to rest on our laurels. We're going to engage with community groups to try and help us. I think the key thing is, again, it's not a volunteer study, but community groups in ethnic minorities, Black men, Asian groups. We want, coastal communities, the traveler community, all of these communities that are small but nonetheless important to have that diversity and transform. What we want those community groups to do is say, look out for this letter. If it comes through, seriously think about taking part. And we're also looking at a package of work for men who have learning disabilities, who can't understand as well as they would. That small group of the population do suffer significant health inequalities. So we're trying to do as much as we can. And again, we can't do it without your support.
And then the last question to close, you talked about the lack of resources if we had a screening program currently, and the fact that we would need significantly more resources. If Transform comes back with the answer that there is a potential screening program that would work and be acceptable to the National Screening Committee, how are we going to manage the lack of resources?
So the only thing I can do, and we can do as a group, and I know the funders are quite keen on this, Prostate Cancer UK and NIHR, and the National Screening Committee is keen on this, is that we continue the dialogue. So when relevant data comes out, they consider it, and they might want to commission pilots. They might want to commission healthcare resource reports, start to tell government this is coming. In 10 years' time, you're going to have to do this. We need to ramp up scanning capacity. We need to ramp up AI. We need to ramp up manpower, woman power, people power in healthcare. And so we're not just going to go one big bang in 15 years, here's the results. I would hope, and I'm pretty confident that because there are so many good people around us, that we will continually share that data when it's relevant, so people can start to think, okay, something's happening. Ultimately, the adoption of a wholesale screening program is going to be a political one. And we all know that. We've seen it in breast cancer and the other screening programs. And that political lobbying will obviously need to come from everybody, including the larger charities and people like yourself in Tackle.
Thank you, Hash. Thank you to you for giving up your time this evening to share your thoughts on screening and the Transform trial. And thank you to all our participants for joining us. We do have a survey which is in the Q&A. So please, if people could fill in the survey response, that would help us greatly to understand whether we've hit the mark with this webinar. So in closing, thank you so much, Hash. We really appreciate you giving up your time tonight. And thank you to everybody for joining us. Good night,
Pleasure.
everybody.
Thank you.
Thank you.